Jersey finger, also known as rugby finger. This video has been produced from a web source that is called OrthoBullets. I would like to thank chapter editor Mark Vitale. Mark Vitale, MD, MPH, is a board-certified orthopedic surgeon and a fellowship-trained specialist in the diagnosis and treatment of hand, wrist and elbow conditions and injuries. He holds a subspecialty certificate of added qualifications in surgery of the hand and upper extremity. Dr. Vitale's expertise includes treatment of arthritis of the hand, wrist and elbow, fractures of the upper extremity, rehabilitation of sports injuries of the hand, wrist and elbow. Citation: https://www.orthobullets.com/hand/6015/jersey-finger. Summary: Jersey finger is a traumatic flexor tendon injury caused by an avulsion injury of the FDP from the insertion at the base of the distal phalanx. Diagnosis is made clinically with a finger that lies in slight extension at the dip relative to other fingers in the resting position. Radiographs may show a bony avulsion if present. Treatment is usually direct tendon repair or open reduction and internal fixation depending on the presence and size of a bony avulsion. Etiology. Pathophysiology. FDP muscle belly in maximal contraction during forceful dip extension. Classification. Type 1. FDP tendon retracted to palm. Leads to disruption of the vascular supply. Treatment. Prompt surgical treatment within 7 to 10 days. Type 2. FDP retracts to level of pit joint. Treatment. Attempt to repair within several weeks for optimal outcome. Type 3. Large avulsion fracture limits retraction to the level of the dip joint. Treatment. Attempt to repair within several weeks for optimal outcome. Type 4. Osseous fragment and simultaneous avulsion of the tendon from the fracture fragment, double avulsion, with subsequent retraction of the tendon usually into palm. Treatment. If tendon separated from fracture fragment, first fix fracture via ORIF, then reattach tendon as for type 1, 2 injuries. Type 5. Ruptured tendon with bone avulsion with bony comminution of the remaining distal phalanx. VA. Extra-articular. VB. Intra-articular. Presentation. Physical exam. 1. Pain and tenderness over volar distal finger. 2. Finger lies in slight extension relative to other fingers in resting position. 3. No active flexion of dip. 4. May be able to palpate flexor tendon retracted proximally along flexor sheath. Imaging. Radiographs. May see avulsion fragment. Treatment. Operative. Direct tendon repair or tendon reinsertion with dorsal button. Indications. Acute injury. 1 cm carries risk of a dip flexion contracture or quadrigia. Postoperative rehabilitation should include either early patient-assisted passive ROM, Duran, or dynamic splint-assisted passive ROM, Kleinet. Open reduction internal fixation of fracture fragment. Indications. Types 3 and IV, for type 4 then repair as for type 1, 2 injuries. Techniques. With K-wire, mini-frag screw or pull-out wire. Examine for symmetric cascade once fixation completed. 2-stage flexor tendon grafting. Indications. Chronic injury, greater than 3 months, in patient with full prom of the dip joint. Dip arthrodesis, indicated as salvage procedure in chronic injury, greater than 3 months, with chronic stiffness. Complications. Quadrigia. Advancement of greater than 1 cm carries risk of a dip flexion contracture or quadrigia. Thanks for watching. Orthopedics Trauma in YouTube. Subscribe.